we want to begin the program, and I'd like to start with 3 expressions of gratitude. The first expression is to Pastor Ben in the House of Prayer congregation. I want to thank you for being willing to host this along with the Southview congregation. The second expression of gratitude is to Kelly Hoffer, and I just saw Kelly walk in. Where is Kelly? Kelly, stand up. This is really Kelly's idea. About 2 years ago, we were over the Hoffer's home, and she said, "Our family is struggling. We have a parent with dementia. Can you help us find a speaker who can speak to our congregation and enlighten us?" And so this is the result. The final expression of gratitude is to Dr. Rosenblum for being willing to spend time with us midweek and give us greater understanding of this challenge that will touch all of us. And I want to just let you know Dr. Rosenblum went to medical school at Columbia University in New York. He then completed his neurology residency at Harvard University and then pursued 2 fellowships, 2 years of fellowship training, and then joined Health Partners in 2010. And that's where I had the opportunity to meet him. He's the director for the Center of Memory and Aging, and he's really a neat guy. You know, his clinical interests include early detection of Alzheimer's disease, imaging characteristics. We depend so much on imaging to aid in the diagnosis of conditions. And then the last area of interest that I'd like to tell you about is a neat treatment modality, and we owe Dr. Bill Fry, a lot of thanks, but delivering treatments through the nose. The olfactory nerve can carry medication to the brain. Who would have thought? And so he's involved in research looking at intranasal insulin for the treatment of Alzheimer's dementia. I also want to thank you for being here this evening. You know, this is really for you, for us. And I want to thank you for taking the time out of your week to take advantage of this opportunity. Let's give Dr. Rosenblum a warm welcome.
Thank you. Well, thank you so much for that nice introduction, Jan, and thank you for the invitation. And clearly you must have a photographic memory because you memorized my entire CV. And thanks to all of you for being here. And is everyone able to hear me okay in the back? Great. So as I've seen patients since I've been here in 2010, you know, I see that there's a lot of questions, a lot of curiosity about this disease, Alzheimer's disease, that affects a good part of the population. And I get questions that kind of, you know, are recurring themes. And so what I did was I thought about those questions that are most common in my clinic, and then I've basically included kind of the responses, the typical answer that I give patients. And so we're going to be talking about a lot of these basic questions, my answers, and I'm hoping that by the end of this talk that this will serve to kind of demystify this disease in your mind. Now, I've taken special care not to go into painstaking details, so you know, it'll be a very succinct presentation, and I know that probably there's a lot of you in the audience who may have questions, and I'm happy to field those at the end of the discussion. So without further ado, I just want to say a couple words about where we come from. So I, as Jan said, I'm part of the Center for Memory and Aging, and we are actually housed at 295 Phelan Boulevard in St. Paul. We have a clinical division that I run, and we have several clinicians who work with me and an advanced practice provider as well. We have a neuropsychology team of 4 neuropsychologists and 4 neuropsychometrists who help extend their work. We have a social worker from the Alzheimer's Association, a research nurse who helps connect our patients to those clinical trials Jan alluded to with intranasal therapeutics. And so we're trying to create a center with one-stop shopping. We also have a research division that's been around for 41 years that helped promote this idea of intranasal therapeutics. This is our building at 295 Phelan, just opened a year ago, and it's a great place. If you haven't been there, we'd love to see you and take you for a tour. I'm having a little bit of trouble with the slides here, so maybe I should go back up here. Is that right? Oh, there we go. Okay. So, as I said before, this is going to be from my own clinical experience, those common questions that I get in the clinical setting. Oops. Okay. So, here is kind of an outline of what we're going to discuss. These are the 6 buckets. So, we're going to talk about the difference between dementia and Alzheimer's disease. Secondly, we'll talk about the clinical features of Alzheimer's disease. What are the symptoms that you may hear about or that you might see in a family member or friend that are red flags versus normal aging? Also, what's it like to live with Alzheimer's disease? What's the experience of that? And then when the disease progresses, how fast does it progress? And what does that look like? We'll talk about some of the risk factors, specifically genetic risk factors for Alzheimer's disease. And then finally, we'll end up in treatment. So the first thing I just want to talk about, and this is the most common question I get, is what's the difference between dementia and Alzheimer's disease? And the fact is that dementia is a very vague, broad umbrella term, hence the umbrellas that you see here. And there are many different types of dementia, and usually the concept of dementia just refers to any cognitive condition where patients have cognitive problems, and as a result of that cognitive condition, there are functional problems. That is, that individual can't do their daily activities like pay bills, take medications, drive, grocery shop, and cook. When you have a cognitive process that affects function, we call it a dementia. Now, my philosophy is that this is a very, well, it's true, it's a very broad category, and having a diagnosis of dementia is just not acceptable when you see a doctor. They need to give you a more specific cause of that dementia. And I think in this slide kind of emphasizes that point. Anything that results in loss of social function, and I defined that before, and then it could affect occupational function. So some of my patients who are working, I had one person who was a business executive, and as a result of her memory problems, she had to retire. So because she couldn't work, we call that a dementia. And Alzheimer's disease is the most common type in 60 to 80% of cases. That's probably why we have this confusion and this tendency to use these terms interchangeably. It's a disorder that specifically targets memory. And this pie graph kind of shows you the breakdown. So these are the most common causes of dementia. There's some other ones that I didn't list here. But Alzheimer's disease is the most common one here in blue. Often patients have what's called vascular disease in the brain. They have kind of hardening of the arteries, white matter disease. It's something that comes with age when you have years of high blood pressure or high cholesterol. And that's 60 to 80% of cases. And this is a memory disorder. And then the next one is Lewy body dementia. And Lewy body dementia is a condition that causes Parkinsonism. Also, patients often have hallucinations early on in the course of the disease. And then they have what's known as cognitive fluctuations, where they're a little bit zoned out. Their cognition is it's almost like we call that encephalopathic, and they're disoriented and they have confused speech. And that's up to a quarter of cases of dementia. So if it's not Alzheimer's disease, it's the next most likely diagnosis is Lewy body dementia. Then there's what's called vascular dementia, and this is associated with dementia in 6 to 10% of cases. These are conditions that result from multiple strokes in the brain. This used to be more common when we were not as good at modifying risk factors like smoking, diabetes, hypertension. Now primary caregivers are very good at that, and as a result, we see this less commonly 6 to 10% of the time. And then finally, there's frontotemporal dementia, which is a young onset dementia, typically affecting individuals younger than 65. It accounts for a very small piece of this pie, 2 to 5%. It has a very unique presentation in that patients have behavioral changes. They're disinhibited. They make inappropriate comments in public. They also may have what's known as a primary progressive aphasia, where there's expressive language difficulty. And even though it's a very small percentage here, if we go to the younger than 65 population, it's at least the second most common cause of dementia in that younger population. So, I want to use this slide to kind of emphasize the importance of being familiar with Alzheimer's disease, not just as a person in the community, but also clinicians need to be familiar with this, no matter what specialty you're in. And this is actually from the wonderful Alzheimer's Association facts and figures that come out annually. And in fact, we have a representative from the Alzheimer's Association, Blaine Turk, who is in the audience, and you can stand up. She actually has some flyers, and this is just a wonderful resource in the community, and so please feel free to find Blaine before you leave today. So the facts and figures. This is the only top 10 leading cause of death in the U.S. that can't be prevented, slowed, or cured. There's just nothing out there that slows this disease down, and that's a problem. 10% of people age 65 and older have Alzheimer's disease. So, when people come to me and I make a diagnosis and they're 67, I say this is fairly common in your age group. Now, by 85, 38% of people have this disease. So very, very, very common as you get older, the major risk factor. There's 5.5 million individuals diagnosed with Alzheimer's. That's works out to about 100,000 in the state of Minnesota. And we expect that to triple by 2050. So it's only getting worse. And then we also see that the number of deaths due to Alzheimer's disease has increased by 89% between 2000 and 2014, and we expect the number of cases to only grow between 2017 and 2025. Costly disease, $259 billion for annual care of these patients. And so you can see how this presents a dilemma for the healthcare system. This will bankrupt the system unless we find a better approach, a better treatment. So another common question I get are about, what are the symptoms of Alzheimer's? It's a very vague, abstract disease because it's not like having a heart attack where it's a heart muscle and there's changes in that heart muscle. This is affecting the self. It's affecting the memory, the very thing that makes us who we are, among other things in the brain. And it's a memory disorder. So if someone has a memory loss that disrupts daily life, that's usually suggestive of Alzheimer's disease. And by the way, this is again from the Alzheimer's Association website of these really helpful kind of tips about what to look for. Also challenges in planning and problem solving. So that individual who is Mr. Fix-It, who then has problems screwing in a light bulb, that is a red flag. Or someone who can't do familiar tasks at home, work, or leisure. So, I might hear a patient who says, they always like to sew, and suddenly they stop doing it because it became more difficult for them. Being confused to time and place, and it's not just not knowing the date because you're not working, but not knowing the month. And over time, not knowing where you are, getting disoriented in your neighborhood, what should be familiar. And you'll have a patient who's been driving to the grocery store, same grocery store for 30 years, and then got lost, just within a 2-mile radius. Problems with word finding, difficulty with writing, also misplacing things and losing things. And, I remember having a patient who preferred to keep their money at home rather than in a bank, and so misplaced, these mounds and piles of, $100 bills and couldn't find them. It was a huge dilemma. So what is going on in the brain? What is causing this? And this is an organic process. Even though it has a very abstract feel, there's something going on in an organ, in the brain organ, in the brain. This is a picture of the brain, and there's a very deep structure in the brain called the hippocampus. Hippocampus actually in Greek means seahorse, and it's because it's kind of shaped like a seahorse. This is an anatomical kind of a picture of the hippocampus next to the seahorse. So you see, I guess, the resemblance if you're creative in abstract thought. So this is ground zero for the disease. It affects this memory organ, the hippocampus. As a result, we get this memory disorder. Over time, it spreads to these other regions of the brain. Now, if we were to look at the brain, a piece of the brain under a microscope, you would see two pathological entities. One is the amyloid plaque, which is this cluster of protein outside of cells, outside of neurons, that you see here. There's another cluster of protein within neurons, within the cell, called the neurofibrillary tangle. And these two entities are what define this disease. These two entities are what drive this disease. And as patients get worse, this gets worse in the brain. And so, when we make a diagnosis of definite Alzheimer's disease, that means you've looked at the brain under a microscope, and you see these things. This is done in an autopsy, post-mortem. And somebody who sees me in clinic, we can say probable Alzheimer's disease, but to say definite, you need to see these things on a slide with the pathology. All right, and so when a patient comes to clinic, what are we doing in the workup? And, first and foremost is taking a good history, getting back to those signs of Alzheimer's that I mentioned before, learning about whether or not a patient is experiencing those things, and then doing some labs. So a lot of times the labs are unremarkable. I know there's this fallacy that you do blood tests and you'll find the answer. In Alzheimer's disease, it's not that common to find any abnormalities from this. Maybe a patient will have a low vitamin B12, which when low can affect cognition, or an abnormal thyroid function abnormally can cause hypothyroidism. But really, do I see abnormalities in this being the primary cause of the presentation? We also check a blood count, make sure their electrolytes are okay, and also make sure the liver is functioning too, because when you have liver dysfunction, that can affect the brain and memory as well. Now, also when patients see me, I will do a very brief cognitive screening test, one of which is called the Montreal Cognitive Assessment. It's a test of different parts of memory and cognition. You may have heard it in the news in the context of Donald Trump undergoing this, and I think he scored a 30 out of 30. And so that's one of many different cognitive screening tests that we can do. The mini mental status exam has been used since the 1970s, but we've learned that's not sensitive enough, and the Montreal Cognitive Assessment is probably the way to go. If, let's say, you're not sure what's going on after you do that cognitive screening, you may subject a patient to a more extended cognitive assessment known as neuropsychological testing. This is when you have a licensed neuropsychologist perform tests of learning, memory, language, what's called executive function, which refers to one's ability to multitask, make decisions, hold information in their head. And then visual spatial construction, one's ability to draw complex figures. So you're looking at all these different areas, including processing speed, to see how patients rate compared to age-matched and education-matched populations. So if there's a difference between their performance and that of the population, you know that it's not due to normal aging. You know that it's abnormal for the age, and it's a red flag. We also like to do an image of the brain because a picture is worth 1,000 words. You can have something like a brain tumor that can mimic this, or a stroke, and so we do imaging. This is a rendition of an MRI. We call this a coronal cut. It's almost as if I were to be looking out at you like this, and there's a slice like going down. And, on both sides here, this is a good way to look at that organ I mentioned, the hippocampus, the seahorse. And you see here this shrunken tissue on both sides. And there's a lot of space. You see it in the white on both sides. And this should be filled with the tissue. Instead, the hippocampus is shrunken, small, and that's atrophy. And this is something that I, as a behavioral neurologist, look for on my evaluation of the imaging. So another common question I get is, how fast does this progress? And I feel that over the past 10 years, we have been more sophisticated in the way that we view Alzheimer's disease and its progression. So there's literature that shows that this disease causes changes in the brain 15 to 20 years before one presents to the doctor with memory symptoms. So there's this phase, we call it the pre-symptomatic or preclinical stage, where you're getting the buildup of those amyloid plaques and tangles I defined before, and there's no associated symptoms. And so when you can first detect changes, that's a different stage, and that's known as mild cognitive impairment. So mild cognitive impairment is a stage where somebody has a memory symptom, and then on the cognitive screening or the testing, they score abnormally, but they're able to do those everyday things like grocery shop and cook and drive. Their function is intact, so it's not dementia. When their function is compromised, they can't do those things, then we call it Alzheimer's dementia. This is going on over many years, so it's about 15 to 20 years in this presynaptic stages, and then the pathology gets worse and worse, and you get into the mild cognitive impairment stage, and then over 5 years, 50% of patients with the mild cognitive impairment diagnosis have Alzheimer's, develop into Alzheimer's dementia. So it's a slow process, but the thing is that the question is, how do we find this population, the presynaptic stage, and maybe if we started a treatment at that stage, you may be able to slow the disease or prevent it altogether. So that's a very provocative research interest. So the other thing I should say is that these biomarkers can be detected in terms of changes in the spinal fluid of proteins, and also there's a special scan called an amyloid PET scan that can detect those amyloid plaques in a living individual, so you don't have to wait to get that slide after they die. And that's another way that we may be able to detect this disease earlier. It's still a research tool, but gradually making its way into the clinical setting. All right, so a little bit more about the progression of this disease. This is the literature. It says on average, people live with Alzheimer's 4 to 8 years after the diagnosis is given. However, we also see that patients may live as long as 20 years after a diagnosis, and perhaps some people in this room have seen that happen with loved ones. Often, though, when I see patients, I don't see much change over a 6-month or a 12-month period. It's usually a slow, progressive condition. There are exceptions to that rule, but on average, there's not a dramatic change in that time period. And as a behavioral neurologist, I have this 10,000-mile perspective of not only Alzheimer's disease, but other causes of dementia, so that vascular dementia and that Lewy body dementia and frontotemporal dementia. And actually, this is slower progressive than those other conditions. So I try to make that clear to anyone I give that diagnosis to. So this cartoon here kind of shows kind of the stages. So there's the mild cognitive impairment stage, and you see ground zero, the hippocampus that I identified before. And then we go to mild Alzheimer's disease that spreads to the neocortex, the covering of the brain, where other areas such as language and executive function and visual spatial construction live. That process in the mild stages can be 2 to 3 years. And then patients go to the moderate stages where it spreads even farther throughout the cortex. And that's about a 2 to 3 year period. And then finally, in severe Alzheimer's, the process is kind of involving the entire brain. And this is when patients are dependent on, bathing, dressing, toileting, and often are in memory care. So a question that I get from patients and their families is, does Alzheimer's kill you? And is this a terminal diagnosis? And it's a bit of a complicated answer. So there's nothing that Alzheimer's directly is doing to the brain to just cause one to up and die. It's more of an indirect effect. So as you can imagine, when this disease travels throughout the brain, patients are less likely to do anything proactively. And so what happens is they're very much confined to bed. They may not be eating. They may be losing weight. And that type of lifestyle puts one at greater risk for a variety of complications. So there was an article in the New England Journal of Medicine, which is considered the best medical journal out there, and it looked at a number of individuals in nursing homes, and they were followed over 18 months. And actually, during the 6-month period, they looked at reasons why these patients died. And there were 3 common reasons. The most common one was pneumonia. So when somebody has a neurodegenerative disease, that's what we classify Alzheimer's disease as, the ability to swallow is often compromised. And as a result, you can get what's called aspiration pneumonia, where the contents of the mouth go into the lungs. The other type of cause of death is febrile illness or sepsis, where an infection goes into the bloodstream and then causes inflammation and fever and low blood pressure, and that often lands the patient in the hospital. And then finally, eating problems. And the eating problems can be choking on food or just, not failure to thrive, refusing to eat. And, it's not practice, at least in this country, or at least, amongst the people I work, to actually put a feeding tube in these patients, because we know that does not improve quality of life. So a lot of patients who I diagnose ask me, what can I do? And, it's always helpful to try and take perspective. And, I see thousands of patients, and still I don't think I have this, the same perspective, the most accurate perspective as some of you in the audience. But at least from my experience, I would say that, as I said before, this is a condition that affects the self. And a lot of people who've been involved in work or have interactions with family members that involves the intellect, this is devastating. People feel helpless. They want to isolate themselves. They also worry about their ability to be independent and being a burden. And, commonly we have that discussion about driving, and nobody wants a family member to just drive them all about because, again, they don't want it to be all about them. But my experience shows that a lot of my patients can be quite active. They're engaging in volunteer activities, either at the Science Museum or in other settings. I have somebody who does wood carving and made me the best, one of the best pieces of this was a heating plate. It was just beautiful work. And then also doing regular exercise. A lot of my patients are, golfing or playing tennis and living their lives. And there's one program that, I'm particularly proud of called the Partners in Dementia program, where we created this program to teach medical students in their first year about dementia and also empower our patients who have memory impairment. And so these individuals meet up for a year. They spend about 4 hours a month with one another. And this is actually a picture of our first cohort of patients/mentors and students. You see the mixture in the crowd. And so this has just been a very empowering experience for many of our participants. And as a result, I also see some of my patients serving as advocates and getting in front of audiences like this and giving speeches, which, again, is not the easiest thing to do. Okay, so the other question that I frequently get asked is about the genetics of Alzheimer's disease and the fear of spreading this to other family members. So I think the easy answer is that most of the time you shouldn't worry. And what people are worried about is what's called autosomal dominant Alzheimer's disease. And typically these are the atypical patients who present in their 30s and 40s. And, there's about a 50% chance that it will be passed down from one generation to another. When you take a family history, it's certainly not subtle. It's pretty obvious. And these are mutations in genes that lead to increase of that amyloid protein, those amyloid plaques. So they're known as presenilin 1, 2, and the amyloid precursor protein. There's another type of patient who I see who come in and they're in their late 50s and early 60s. And certainly that might just be an unlucky situation. There is, however, a genetic risk factor that does not guarantee that one will get Alzheimer's disease, but will increase the risk. And that genetic factor is known as ApoE4. If you have one copy of this, you're 2 to 3 times more likely to get Alzheimer's. And if you have 2 copies, it's about 8 to 12 times the risk. And if being a carrier for 2 copies can cause this disease to present 8 to 10 years earlier than it would have, and that might be explaining why these patients get the disease in their 50s and their 60s. And then finally, there's sporadic Alzheimer's disease, and this is what I see most commonly, patients who are in their 70s and 80s. And I think the short answer is that if you live long enough, from that data I presented earlier, if 38% of the population who live to 85 have this, well, it's just a common condition. It's probably a mixture of different genes, risk factors that are in the environment interacting with one another, and we still have yet to tease out that mechanism. So let's move on to the treatment of Alzheimer's disease. And remember what I said before. We have this condition. It is characterized pathologically by these plaques that are outside of cells and these tangles that are within the cells. And ultimately, if we want a drug that's going to slow or modify or cure this disease, it has to interact with these pathological entities. We have nothing that's FDA approved that does that right now. To emphasize this point, I want to direct you to this graph here. So you see time on the x-axis, cognition on the y-axis. And so this dotted line here is kind of an evidence of somebody who has Alzheimer's disease, and their cognition goes down over time. The drugs that we have available right now may boost this up temporarily, but it doesn't really change the decline at all. And if you were to take away the drug, patients would be just like as if it never even happened. So, the punchline is that the drugs that are available right now don't affect the course of the disease. What we want is something like this line here, where you give the drug and your decline is slower. It's not like this dotted line. It's more like this solid line. And even better is having something that will arrest the disease and reverse it. And that would be this treatment here, where the cognition just stays the same. And there's absolutely no decline over time. You know, I think it's important to think big because, again, this is, you know, if we were to go back to the early 20th century, we were looking at cancer in the same way that we're looking at Alzheimer's right now. And look how far we've come in cancer therapeutics. So what are these memory pills? How do they work? And there's a big category of disease known as the cholinesterase inhibitors. What they do, and the most common one you've probably heard about is donepezil or Aricept, is that they inhibit the breakdown of a chemical that's lost in the brains of patients with Alzheimer's disease. This chemical helps brain cells communicate with one another, and as a result, patients may feel sharper with the drug. So it's a symptomatic treatment. It's almost like if you had an injury and you wanted to take, or back pain, you wanted to take a drug like ibuprofen or Tylenol. That's a symptomatic treatment. It's not getting to the bottom or the heart of the cause of the back pain, but it's treating that. And so I have the same philosophy about these drugs. If someone is really bothered by their memory symptoms, then I will prescribe them. If they are not bothered and they don't want to be on any new medications, that's okay as well, because this is not neither of these drugs are disease-modifying. The most common side effect with Aricept or donepezil or some of these other drugs known as galantamine and rivastigmine is stomach upset. So 20% of patients have diarrhea, nausea, vomiting. For that reason, I usually start at a lower dose, a half a tablet for a month, and then one tablet thereafter. Pharmacists have not, at least the ones that I've worked with, have not really come to the realization that this drug causes vivid dreams. They're always dispensing it at, 10 milligrams at night, and it causes vivid dreams. Take it in the morning, and you won't get the vivid dreams, or the insomnia that's associated with it. And then there's another drug that's approved. So the cholinesterase inhibitors are approved for mild, moderate, and severe Alzheimer's. Namenda or memantine is approved for moderate to severe Alzheimer's disease. So there's no evidence that it works in patients who have mild Alzheimer's. So I don't prescribe it until somebody has moderate stage. And it's a twice-a-day drug. And similarly to the cholinesterase inhibitors, this is working by helping brain cells communicate with one another. Doesn't do anything about those plaques and tangles. The most common side effects are headache, dizziness, and confusion. In my experience, this is pretty well tolerated, perhaps better tolerated than the cholinesterase inhibitors. And I don't hear a lot of complaints from patients. But again, I don't hear that it's having as dramatic effect as the cholinesterase inhibitors like donepezil. I want you also to realize this pearl of wisdom is that the non-drug interactions, the non-pharmacological interventions that I can make as a clinician are more important than the drug interventions. And it might seem paradoxical, but it's just where we are with Alzheimer's disease in 2018. So one of the most important things I do is connect patients to community resources like the Alzheimer's Association. There's also quite a lot going on with the state government. There's a senior linkage line, and both of these resources will help families with figuring out, navigating what services may be available in the community to help them through this disease. The other thing is that there was, I'm going to try and go back here, we try to focus on healthy lifestyle. And there's a workbook that we put together with the Alzheimer's Association known as the Living Well Workbook. You see that here. And it's focusing on, a lot of these everyday things like physical exercise, specifically aerobic exercise. So, for instance, there is some data that in patients who are at risk for dementia, if you have a very physically active lifestyle, it may reduce the risk over time. So, we're talking about being on treadmill, elliptical, exercise bike 3 times a week for 30, 40 minutes at a time. If someone has some type of, mobility issue, I often talk about yoga or Tai Chi. Also keeping cognitively active, and that has to be something that one is interested in, whether it's reading, writing, playing games. If someone does not like doing word finds or crossword puzzles, find something else. This book, and I have the link here, has a lot of the evidence-based activities that one can recommend. And then also ensuring good sleep. And so we know that there's disruption of the sleep-wake cycle, especially in advanced stage Alzheimer's disease. But earlier on, it's important to get that 7 to 9 hours of sleep each night. So these are things that patients can feel empowered to do to help promote their own brain health. So safety is quite important. So I'm often recommending a team approach to things like finances because, again, I've had situations where I've had a patient where he's in business, he's been taking care of the finances for decades and then forgets to file the taxes, and that causes problems, and then is forgetting to pay bills, and then may become a victim to various scammers, and I've seen families lose their home over this or go bankrupt. And so this is something that we try to hone in on. Also medications. And this is why dementia or Alzheimer's disease and other associated diseases, this is a disease, these diseases don't just affect a neurologist such as myself. They affect everyone in the medical field. So the primary care doctor who's prescribing insulin for diabetes or a blood thinner for atrial fibrillation, if that patient is forgetting to take the medicine or taking it multiple times because they forgot about doing it in the first place, that's catastrophic. That can lead to unnecessary emergency room visits or unnecessary hospitalization. So it's important to have a team approach to the medications. And then patients may forget to eat, usually in the more advanced stages, and so also ensuring that they have a source of meals. Driving is always a contentious issue, and it's one of the hardest things I do to have that conversation with patients about driving. And, where I was trained at UCSF in my fellowship, in the state of California, you get an Alzheimer's diagnosis, the law is you lose your license. I'm not in agreement with that. And in Minnesota, it's up to, I'm kind of the one who makes that decision about driving. And, like everything else in medicine, it's important to get objective data. So we have the luxury of having an occupational therapy department. Kathy Kiefer does these driving evaluations. It consists of several parts. The first part is some pen and paper tests and then also a driving simulator. And then if a patient struggles on that, they may move on to a behind-the-wheel driving test. And based on that assessment, there will be recommendations about driving. And so these are kind of common quotes I hear. I have a perfect driving record, not one accident in my entire life. But also there are certain skills that are compromised. Just like when you have macular degeneration and you lose your vision, that's critical. Same thing with the cognition. So processing speed, executive function, memory are all really important. And then, the other fallacy is after they diagnose me with Alzheimer's disease, they'll take my car away. It depends on how one performs on that OT assessment. And there's plenty of patients who see me in clinic who are either permitted to drive or drive with self-imposed restrictions. Okay, so I just want to summarize the take-home points. So number one is that dementia is an umbrella term, and there's many different causes: Alzheimer's, Lewy body dementia, vascular dementia, and frontotemporal dementia. The most common cause of dementia is Alzheimer's in 5.5 million individuals, and that it's a slow progressive memory disorder over 4 to 20 years, and patients can still engage in meaningful activities, and that there are no medicines that slow Alzheimer's disease, but there are a lot of non-pharmacological, non-medical interventions that can improve quality of life and connect patients to resources that make a difference. So that is all I have for you, and I'm happy to take any questions.
We have a mic, just so everybody knows. I'm going to hold it.
Do you find Alzheimer's is more prevalent in certain races or cultures?
So the question was about Alzheimer's prevalence in certain races and cultures. And, if you were to look at the demographics of my patients, it could certainly be a bit more diverse. But there is literature that suggests in the African American population that actually rates are higher. And also that's also holds true for the Hispanic population as well. We don't know why. The other thing is that there are other factors such as the things that can cause that vascular disease in the brain. And I said before, often Alzheimer's disease is a combination of those changes of plaques and tangles and some white matter disease in the brain. And whether certain racial groups are at greater risk for the vascular changes, we're not sure. But in those groups we know that the rates are higher. I think behind you.
Can you speak to Dr. Bresdeden's protocol for trying to maybe slow Alzheimer's?
Yeah, so there's a lot of publications and books about with labels about curing Alzheimer's disease and being free of it, and I wish that were the case. It's not the case. Now, a lot of the things that these physicians are writing about are somewhat related to what I talked about: lifestyle, having a certain diet, being active. They might mention more about certain vitamins and minerals that, I'm more likely to recommend something that's been proven in clinical trials. But, the literature is out there. It's not enough for me to recommend it to my patients. At the same time, I don't find what they say harmful. So if this is something that gives hope and makes one feel proactive, then I encourage my patients to carry on. Yes?
My mother died of Alzheimer's, and now my sister has been diagnosed. And I went to an appointment with a neuropsychologist with my sister. Mm-hmm. And he came to the conclusion that she has my sister, my mother has since died, has several different kinds of, and he said dementia / Alzheimer's. Mm-hmm. You know what I mean? So is that possible, number one, to have many different kinds at one time?
Yeah, so that's a good question. So whether or not you can have multiple types of dementia at once. So you're getting to the concept of mixed dementia, which I didn't have a slide on, but that can happen. So a mixed dementia, the simplest form of that is Alzheimer's plus the vascular disease in the brain. Also, some patients may have Alzheimer's disease and now Lewy body dementia together. It's rare for frontotemporal dementia to also have Alzheimer's or some of the others, but usually Alzheimer's and Lewy body and vascular dementia, those three may come together. Realize that when a neuropsychologist does an assessment, everything's based on the cognitive assessment that they're doing. It's one piece of the puzzle. And you need a clinician, a physician, to put together the results from that report with the imaging, with the labs, with the history, to make their final diagnosis. And so there are times where a neuropsychologist might say, I think this patient has Alzheimer's disease, and then I'll see them and I'm like, well, that can't be. So it's also important that you have whoever is the clinician who ordered the test, that they're being proactive to read it over and see it in the overall context.
Can I ask another question?
Sure.
Do you have, with Alzheimer's, many skin eruptions?
So skin manifestations in Alzheimer's disease, I'm not aware of any connection. Parkinson's disease does have a connection to the skin. So.
I have a friend that was diagnosed schizophrenic at 18, very bright, and lives in a group home, continues to age, and I'm wondering where to start right now with her. She definitely is delusional often now. That's not always, but it is. Recently went catatonic for the first time in years. Where do you start? Because we're noticing some memory things, yet the psych eval, and yes, she's on significant medication.
Yeah. So when I hear delusional and catatonia, you notice in my presentation I said nothing about that because that's not something that I usually see in Alzheimer's disease. Delusional, you might see it in more advanced stages. And so, it sounds like figuring out, is it psychiatric, is it organic, neurodegenerative, that's what needs to be done. And so seeing a memory specialist, a behavioral neurologist, that probably would be a good thing to do, I would recommend.
Can you talk a little bit about how vision is affected by Alzheimer's, where a person may not have anything wrong with the eye as such, but their vision is dramatically affected?
So in Alzheimer's disease, the condition, if we go back to one of the slides, over time, it will spread from the hippocampi to other areas in the brain, other areas in the neocortex. And there's an area in the back of the brain called the visual cortex. And this allows us to process information in our visual field. And in those advanced stages, the disease spreads to that region. And it's not necessarily an eye problem. It's basically the eye is the sensory organ that directs all this to the brain. And in the late stages, this disease spreads to the back area here. And so that might be a good explanation of what you're observing. There is a variant of Alzheimer's that affects younger patients, usually called posterior cortical atrophy. It's almost as if the process is reversed, and rather than starting in the hippocampus memory area, it starts in the visual area. These patients often present to the eye doctor, who finds nothing and then sends them to a specialist such as myself.
I did. Not too close. I'll talk loud. Plaque. It seemed to me that you were saying that it's something that they find if they do post-mortem things. So I really have two parts. One, is there any research being done to be able to examine the brain before death? Are people trying to find a way to do that? And secondly, is there research being done to do something about plaque?
Yeah. So, to detect, so being able to look into the brain before someone dies. So I had mentioned the amyloid PET study, which is a type of scan that get a radioactive ligand that goes into the bloodstream, and it goes into the bloodstream and binds to any plaques that are present in the brain. You can do that. We've done this on 60 patients in our group, and you can see this plaque in anyone who has it who's still alive. If you see that, you're more likely to diagnose Alzheimer's disease. Now, of course, that's one part of that dyad. So we have to also consider those neurofibrillary tangles. So there's another type of imaging that's even earlier in its history that's known as tau imaging, where those neurofibrillary tangles are consisting of this tau protein. And this is a different ligand, a different type of PET scan. You give the injection, it binds to the tau protein, and you can see it living in the individual's brain. So in the future, we hope to see a PET scans where you can get an amyloid scan, a tau scan, and see those entities before death. And that has to be done for us to better manage, diagnose, treat this disease. Your second question is that, we're doing some of these trials at the Center for Memory and Aging where drug companies are designing these antibodies that will bind to the proteins, the amyloid plaques, and take them out of the brain. And so theoretically that sounds great. some of the trials have been, less than exciting or, fulfilling thus far, but it's ongoing work. And, going back to the different stages of Alzheimer's disease, right now there's a lot of studies looking at mild cognitive impairment because we feel we can identify this well before patients have reached a stage where there's not much that can be done. Also, in the genetic Alzheimer's disease, those patients who have those autosomal dominant mutations, if they're a carrier of, let's say, a presenilin 1 mutation, they're destined to get Alzheimer's disease. Their father probably had Alzheimer's when they were 49, and that child who's a carrier for the gene will probably get it at 49 too. If you put them on a medicine before they reach 49 that theoretically might treat Alzheimer's disease and the person develops dementia at 60 or not at all, that's a positive, outcome. So that's kind of where we're headed. We have imaging that will allow us to see those plaques and tangles in a living individual, and we have certain types of drugs that are antibodies against those pathological proteins, and then we're figuring out ways to treat at the earliest stages. Yep.
I have been reading that a diet high in sugar is bringing a lot of this dementia on. Is there any truth to that?
I'm sorry, diet high in sugar is?
A diet high in sugar. I've been reading that's kind of bringing on a lot of this dementia.
I think we're all in trouble. So, there is a theory that Alzheimer's is a type 3 diabetes of the brain where sugar is not metabolized properly, insulin is not being utilized, and I guess that may be connected to your question, but sugar in itself in high amounts, it's uncertain exactly. It's not let me put it this way. If you read the textbook, it doesn't show sugar as being a risk factor for Alzheimer's disease. So I think everything in moderation. If you wanted to protect your brain, have the Mediterranean diet or the Mind diet, eating lots of fish, lots of fruits and vegetables, avoiding saturated fats, olive oils instead of butter, and things like that. Yeah, so this is something that we are researching right now. We have a clinical trial looking at mild cognitive impairment in early stage Alzheimer's disease using an intranasal approach. This, as Dr. MacGyver alluded to, is a way to get a drug directly to the brain, which is a very privileged space. There's the blood-brain barrier that kind of keeps large compounds out, but you can bypass that because the drug goes into the nose and travels via the olfactory and trigeminal nerves to the brain. So insulin is a very large protein and doesn't get across the blood-brain barrier, and based on that theory of Alzheimer's being a type 3 diabetes of the brain, theoretically maybe insulin may make a difference. So we're looking at an intranasal insulin for this. So again, it's research. It's nothing I would prescribe, and based on the results, we'll be able to tell you more and give you recommendations.
It sounds complicated, but a couple questions. What are the primary sources of the funding for the researchers in this field? And because of all the interrelationships, how long does it take to become a competent researcher in this field?
Yeah, so, the major funding for most of the research is from the National Institute of Aging, so it's federally funded. A lot of this that I've referenced. At the Center for Memory and Aging, we actually receive quite a bit of philanthropy, and so some of the studies that would be a little bit, I guess, on the edge, like the intranasal approach, that's something that we funded through philanthropic dollars. So, and so there are other philanthropic organizations throughout the country that specifically have targeted Alzheimer's disease, and so, one can apply for grants and things like that. Pharmaceutical companies also offer grants. Usually they want you to be looking at their drugs that they're producing. To be a researcher in the field, I consider myself a clinician/researcher. We have other people who do research full time. For me, I did 4 years of undergraduate with a neuroscience major, 4 years of medical school, and then I have 4 years of internship and residency, and then 2 years of fellowship to subspecialize in my area. If someone has a PhD, they may not need to do the residency, but they'll probably have to specialize in a certain area, like a postdoc or something like that. So,
is there a correlation with high aluminum in the body and Alzheimer's?
Yeah, so there in the 1980s, there was a theory that aluminum was a major cause of Alzheimer's disease, but, really, this is such a common disease. How often are we exposed to aluminum except when we put foil over the food that we cook? I mean, that's been disproven. I wouldn't worry about it. It's basically 1980s news, and we're beyond that now. So. One over.
Talk a little bit about the self-awareness of a person with Alzheimer's and the problem of denial of limitations.
Yeah, so questions about the self-awareness in Alzheimer's disease. And, I see a mixed bag. So I see those early stage patients who come in who actually ask for the appointment and just feel they're not producing at work, or, just feel like they weren't like they were 5 years ago. And so there is insight maintained. There's some people who don't have insight. And the very organ that allows us insight is affected by this disease. So it is quite common. Usually, I would guess probably in a primary care practice to see this, where patients just don't have any insight into the fact that their memory is off, or that their behavior is different. And it's certainly a common phenomenon. We need the frontal lobes to help us self-monitor our behavior. And, a lot of times in the parietal cortex, the sense of oneself is also controlled there. And this disease spreads to those areas. As a result, there's that lack of insight.
How do you handle that then when clearly they've been diagnosed, but they'll say to you, well, I think I'm getting better.
Yeah. So I try not to, dismiss that, but, it's important to have a good caregiver who you can talk to and kind of be, as a clinician, and be able to make sure that they're looking out for them. And I try not to argue or escalate anything, because it doesn't get you anywhere. But the Alzheimer's Association has actually a very nice tip sheet about avoiding escalation and agitation. And this is actually, we have it embedded in our electronic medical record, so we can call it up. I usually print it out for families. So.
Can I ask a final question?
Sure.
And then, well, thank you for being here. What would you say that churches could do to support the caregivers of Alzheimer's patients?
Yeah. So I feel that it's, there's been the ACT, that's a great question. There's been the ACT on Alzheimer's collaborative, and one of the goals is to create dementia-friendly communities. And this is a great place where communities convene and come together. And I think it's really important for, anybody who is staff, figurehead at the church, to be acquainted with this disease, understand that, the effects on patients, families, the whole community. And, I have 30 to 60 minutes with patients, and it takes a village for this disease. And so having that familiarity and also being comfortable with having these hard conversations and supporting, making the church as a dementia-friendly community as well. Because we know, I'm Jewish, I don't go to, I go to synagogue, but I'm sure it's the same thing, is that there's certain ways to conduct a service that are dementia-friendly or child-friendly, and other ways that may not be so friendly. And so being mindful of that is also important.
This question is probably for Blaine. Do you know of any classes or material that's available for caregivers that are taking care of people, of course, that have Alzheimer's, in mean, do you let that, I mean, is that readily available for people? My sister-in-law has Alzheimer's, and her partner is, I'm sure, has a very trying day every day of the week. And I don't know that she's getting a lot of help.
As I said this Sunday, I love hearing myself speak. Yes, we have a helpline that just recently has been taken over by National. So every time you call our helpline, which I have the cards and I have information for anybody who wants to see me afterwards, you call and they have all the support groups, all of the information on their own website that they can tell you all about. We also have it on our website, but I wouldn't recommend that because our website is right now undergoing some massive changes. So if you want it right away, call our helpline number, which I can give to you if you're writing down anything right now. And I also have, like I said, some cards. So it's 1-800-272-3900, and this is not just a crisis helpline or a crisis hotline. You call with anything. You need resources. You need to find a doctor. You need to find Dr. Rosenblum. You need to find anybody, support groups, education classes. If you just need help, you don't know what to do, and you have a question, anything. It's not crisis. It's absolutely a hotline that you can call 24/7, and you'll reach someone who has all the same resources as we do at our chapter.
Okay, as we draw to a close, I'd like to thank Dr. Rosenblum on behalf of House of Prayer Lutheran Church and Southview Seventh-day Adventist Church. This was very informative. A lot of resources we've learned tonight for a very important topic, something that affects us all. And once again, I've been asked to direct you to the table where we have some resources out in the narthex. So be sure and pick that up, and I'm sure that there'll be time for a couple more questions if they come to mind. So thank you so much, Doctor.
Yeah. My pleasure.